Okay, let's begin. So, thank you everybody for logging in. My name's Tom Allen. I'm the country manager for Checkware here in the UK. We are doing this our first in a series of different webcasts we're going to be running this year, covering results from customers' projects where our solutions are being used. Pretty busy session today, which is great. We've got some participants from a number of different countries. This session should take around 30 minutes. Feel free to jot down any questions as we go through, and then at the end we'll have an opportunity for a Q&A window to come up where you can type those in and I will aim to answer them as best I can. So, starting off with the agenda, so today basically we're discussing a project we're involved in with the Memory Assessment Service that's run by Manchester Health and Social Care Trust. So we're going to start with an introduction of who we are, and also setting the scene, the backdrop for that project. We'll then go through the project itself, how it was run, and finish off looking at the impact of the project. I mentioned at the end we'll have a Q&A session, so just make a note of your questions as we go through, and we will address them at the end. So starting off, thought it'd be useful, a number of you here know who Checkware are, a number of you don't. So just to give some background, Checkware is an e-health solution. We are used for simplifying the collection and reporting of clinical information across three sort of key areas, so clinical treatment, research and outcome reporting. We started in 2007, founded by health professionals in Trondheim in Norway. We're now working with about 170 different customers across Europe. That's served from our bases in Norway and in the UK. So, the project with Manchester Health and Social Care Trust began with the backdrop of Prime Minister's Challenge on Dementia. So, for those of you that aren't familiar with this, it's a programme with the aim of making the UK a global leader in dementia, diagnosis and care, as well as leading the way towards possible cures. Probably, for those of you that don't know, this programme consists of around 17 different key objectives. Within there, some of the key medical targets include early and more rapid diagnosis, good quality care in the early stages of dementia, and attempting to delay progression, as well as good ongoing monitoring. Why? Well, the World Health Organization has named dementia as one of the most significant health challenges facing the developed world. It expects cases to rise in the region of around 130% over the next few years. Looking at the UK specifically, the Alzheimer's Society estimates that there's around 800,000 people in the UK living with some form of dementia, and they expect those numbers to rise by 2 million within the next 6 years. So it seems a real challenge for the UK government. Looking more specifically at Manchester, the Greater Manchester region, which consists of the city of Manchester and then a number of outlying towns, has a population of around 2.6 million people. It is estimated that within there, around 33,000 people are living with dementia. The Manchester Memory Assessment Service receives, it's a pretty busy service, around 1,200 referrals per year from primary care, or over that number. And that's split across the three sort of main sites of the Memory Assessment Service, which is split into a north, central and south regions of the city. The Memory Assessment Service here collaborates with the University of Manchester, which is known internationally for world-class research into dementia. However, Manchester does have a number of significant challenges that it faces. So, example, the table on the right here is a ranking of health economies in Manchester, or sorry, health economies in the UK. We can see, if you look to the bottom of the list, 150th out of 150 for premature deaths is Manchester. So it performs pretty badly. It has certain challenges in this area. We also look at the three next worst performers, and they're all in the same region. So it's not just Manchester, but it's a regional challenge that's faced there. And in terms of dementia diagnosis, Manchester's running at around 44.5% of those with dementia having a formal diagnosis. To put this into perspective, as part of the Dementia Challenge, the target for diagnosis rates, if my memory serves me correctly, is 66 to 70%, so they're running some way behind that. So with that in mind, back in May 2012, the Memory Assessment Service team in Manchester, they recognised there was a need for change, and as part of the service improvement programme that a number of the key individuals in that team were working on, they established an expert working group, and they worked with the aim of examining the current method of service delivery, with the aim of improving efficiency, creating common care pathway, and also a single assessment and reporting template. But before they could begin, there's a number of fairly significant challenges were identified, and that led us into the project that I'm about to talk about. So first of all, the challenges, well, there were three sort of main areas. So one was inconsistent service delivery. So you might recall I mentioned they're based across three services: north, central, and south of the city. Well, even though they're part of the same organisation, they run three different service models within that. They also have three different assessment procedures, so there was a lack of consistency, and therefore potentially a lack of outcomes across those services. The pathways were too slow, so there was too many weeks from when a referral from primary care came into the service to when the final diagnosis was delivered. And then there was no system really for measuring outcomes or storing other data that could be easily accessed for analysis on service performance, outcomes, severity ratings, etc. It existed, this information was there, but it wasn't in any sort of manageable form. So at this point, the expert working group agreed a main aim for the memory service, and that was to develop the memory assessment service system into a world-class dementia service. And that's when they were part of the work closely with the university, which is recognised as being world-class in this field. So it makes sense that the clinical side of that should also be as consistent. So a few points came out of this. So one was to incorporate research and innovation, so closer links with the university, to establish the service into a streamlined, fast and digitised service with measurable outcomes. And really this, by fulfilling these, then they would ensure that the service could continue to be commissioned in the future, so really securing the future of that service. So looking at different ways in which they could achieve this, one of those was to look at the assessment process. Now this, at that time, was dependent on static patient record system, and they wanted to look at moving that into a secure mobile and remotely accessible solution. So it's that point that we started working with the service. They were aware of Checkware, they were aware of what we were able to offer, and so they decided to work with us on a pilot. And the pilot had three distinct aims. So one was to address whether or not this tablet-based assessment solution could be adapted to the specific needs of their service. If it could, would it be an improvement? And if it is an improvement, what sort of an improvement was that? Quantifying that improvement. Once we all understood this, we initiated a project, and that was focused just on the north of the city, led by Dr. Ira Leroy, and we initiated a project with the methodology based in the principles of improvement science. So not just about running a project, but if indeed there is an improvement from that project, to make sure that improvement sticks and can be deployed more widely. So this is a diagram that summarizes the process. So kind of kicking off the process was really about engaging with users, clinical users, nurses, doctors, who would be working within the memory assessment service, making sure they're on board, making sure they feel part of the project and supportive of that. Next was to establish the baseline. So where are we now? If we don't know where we are now, then we don't know whether we've made an improvement. So making sure we had a clear idea of where we were. Then was to introduce the changes. So we took a pretty slow, I won't say slow, but a careful and iterative process to the project. So We worked to the principles of PDSA cycles, which I'll talk about a little bit more as we go through, but really a case of implementing the change on a small scale, reviewing how effective it's been, and then making changes and so on. And then finishing off by actually evaluating and measuring the change as a result of the project. So starting off, we engaged with service users. So a survey was conducted to gauge attitudes within the clinical users. These pie charts here indicate the results of some of the questions of those surveys. So will an assessment solution be an improvement? Fair to say we had some pretty encouraging feedback from these. So 3/4 said yes, they thought it would be an improvement. And when asked would they like to be involved in a pilot, then a greater number said yes. So it showed that there were some skeptics in there, but they were actually quite keen to be part of the project as well. Next was measuring the baseline where we were at the moment. So this graphic here gives a sort of fairly brief summary of the process. So a patient is referred into the memory assessment service from primary care, a number of questionnaires completed, some narrative on history, family history, medical history, etc. And then the nurse from the memory assessment service would then complete all this information, head back to somewhere where they could access the patient record, type that in, and complete a report for the psychiatrist to later on review and deliver a diagnosis. When we looked at obviously excuse me, it looks like we had a minor technical glitch there, but I think we're back on. So the dark blue, 60 minutes of that time was spent facing with the patient, so collecting information, completing questionnaires, and filling in relevant forms. Then 30 minutes would be spent completing assessments, filling them in, scoring them for the cognitive reports, different assessments for depression and anxiety, alcohol abuse, measuring daily activity, and measuring whether getting an idea of other comorbid physical health conditions. And then a further 90 minutes spent actually compiling the final reports that went to the psychiatrist and then went into the patient record system. There's an interesting point that came out of this is when the process was reviewed more closely, it was seen that there was error in around 16% of the questionnaires and assessments that were scored manually. So cognitive measures and depression tests, there was an error rating of around 16%. Obviously, that can be quite important because that can be the difference between a positive or negative diagnosis in dementia. So the next step was to introduce new methods. So we worked with the team to take some of the measures and take the information that they collect on paper at the moment and put those onto a tablet device. So the scenario then was a nurse would meet a patient either in their home or elsewhere. They would complete the various different assessments and fill in that information directly into a tablet device. And when completed, that would be uploaded to a place that was accessible centrally, and later would be integrated into the patient record system so that can be made available directly into the patient record. I mentioned this process of PDSA cycle. So we didn't introduce the project or the solution on a big bang approach. It was done really on small iterative steps. So the expert working group team involved met every week over the course of 18 months. They were also guided by a health improvement team that were based at Salford Royal Hospital, and they had regular 3-monthly mentoring sessions as part of that. There was also monthly progress reports submitted which highlighted any achievements as well as barriers and breakthroughs that had been made. So it helped to focus the team on making sure that the project stayed on track. So next, we'll look at the results. What was the impact of this project? Well, going back before we start, looking at the objectives. So first of all, can a tablet-based solution be adapted to the specific service needs? If so, is it an improvement? And if it is an improvement, how big is that improvement? So a number of questions or surveys were conducted again with the same users. So in order to answer the first objectives about whether the assessment solution could be adapted and would it be an improvement, before was still pretty positive, as we said at the start, was about 75% thought that it would enhance their practice and make them more efficient. But that number increased afterwards to over 90%. So here shows that we won over some of the skeptics with the project and saw that it had a genuine impact, a positive impact on their practice. Next was around quantifying that improvement to support a business plan to enable wider implementation. So we looked, if you remember the pie chart, looking at actually how long was taken producing the final memory assessment service report. Well, before it was 3 hours, 180 minutes. But by automating the back office processes, the scoring and compiling of reports that needed to be done back at a computer terminal after, that time fell to just 60 minutes. So a very significant improvement. That's really where the biggest gains were made. There's also in there, by automating the scoring, we also enabled them to eliminate scoring errors. So at the start, we mentioned 16% scoring errors. Afterwards, then that human error element had been eliminated. So, in conclusion, the system was accepted and indeed embraced by staff. We saw that in the increase in positive views on the opinions of the solution. It's an efficient and effective method for producing the assessment reports. It was also the opportunity to better document and measure treatment outcomes. So one of the things that Checkware does is we're capturing data from the assessment reports, not only on individual patients, but enabling them to get an aggregate view of that data. So starting to have a structured and systematic collection of data to review how the service is performing based on that data. And really the key point here is the bottom one there, is that because of the time saving through automating back office processes, there's a real potential to double throughput of referrals. So report creation time dropped from 3 hours to 1 hour. There's enough scope in there to see another patient and carry out another assessment, even with some extra time for other duties. When we talk to the team, look back at other lessons learned, a key one really was engaging stakeholders. So one thing I haven't talked about before in the presentation, but the team worked closely with the information governance team, chief operating officer, research and innovation director, and also had support from the CEO as well. So they were aware of the project and were fully behind it. They also recognised there's applications across other specialties. So moving forwards, there's a greater opportunity outside of just the memory assessment service to automate other back office processes and data capture processes that are present elsewhere. They talked after the project about how important the monthly progress reports were. So documenting breakthroughs and barriers and really celebrating where breakthroughs have been made and using that to keep momentum for the project and keep it on track was really quite key. And also talked about how it was quite empowering to look back at achievements that had been made throughout the project. So before we head to questions, I just wanted to also take this opportunity to thank the team from Manchester Health and Social Care Trust for working with us on this and helping us pull this presentation together. It was led by Dr. Leroy, but also involved Sandra Critcher, Barbara Chavanduka and Anne-Marie Hendry as the key users. If anybody would like further information and more detail on the results of this project, it is subject to a paper that has been published in the British Journal of Neuroscience Nursing anytime now. I think it comes out in January. If people would like a copy of that, they can drop me a note and I will happily send that through to them. So the question and answer pod is being dropped into your view now. If you have questions, please do feel free to drop them into the window and I will answer them as best I can. Thank you. So, question from Tony here. So, how do you upload the static reports, so static records, to the static record system? So, Tony, just to elaborate on that, do you mean as in the patient record system? Yeah. Okay. So that we have within Checkware we have an API. So it basically allows us to share data across to and from other systems. So if you have a patient record system in place, which I suspect you do by the fact you're asking that question, then we would set up an integration. Typically, the patient record system has a method for receiving and also sharing data from other systems. So there would be a discussion around understanding how that system works. Many NHS organisations I talk to have trust integration engines, which makes it a lot easier. Those that don't, we need to understand how our API would need to talk to the other solution and collect or deposit data into that system. But technically possible, but we just need to understand a bit more about that. But it would be done on a day-to-day basis. We'd expect that to be done either as a live feed into another system, or as a kind of a daily data dump to and from the other system. So to share that data and upload it into the patient record at a set time every day, usually sometime in the middle of the night, and that would then become part of that patient record. Also, the project ran for, I think it was, looking back, was about 12 months in total. So we engaged with them in early 2013. At that point, they'd already been working on their service improvement program, but we got involved with them around that sort of time, and it ran until sort of early 2014, maybe middle of 2014, a bit longer. So, Yusman, how flexible is the reporting part? I mean, is it standard predefined analysis, or can we define the analysis ourselves? So, we work typically, that would depend on what reports or what questionnaires and data you're capturing. So, we work with with standardized tools typically. So, for example, with Manchester, we worked on that we used the ACE3 was the measure of the cognitive tool that we use predominantly. So that's a standardized tool. So the reports from there were standardized reports that came out of that, but there's still the facility for customers to basically define and predefine which fields you want to report on, and to produce kind of customized reports. When we tend not to advise to change the questionnaires and the tools themselves, because often they're based on, or they're validated by the research from which they were created. So there's a validity element to that needs to be protected. But once you've got the data, how you present that back to yourself and analyze that data is really, it's up to you, and we would obviously support you on that. Okay, Tony, so you're using Rio. Okay. Okay. So Tony, does the system allow for history taking forms to be uploaded? Yes. So you can have structured questionnaires, but you can also have, I guess, kind of narrative forms in there as well. So that's what we introduced. So when we started working with Manchester, started off with basic questionnaires such as the audit for alcohol abuse, and then the ACE3 as the kind of key cognitive measure. But then as we adapted the solution through these iterative cycles. We added in risk assessments, family history, medical history, and where there is a requirement for more narrative there. And that would be the case would be then that the nurse in question would either, if they were quick at typing, type that into the tablet device as part of the consultation, or complete it in the car afterwards if they felt more comfortable taking down more narrative details as with a pen and a paper. And it's around finding what works best for you and for that particular individual. We found actually this is not I don't think is different anywhere else that I've worked, but you find when you work with services that you've got people with very differing levels of IT literacy, I suppose is the best way. Some people are very comfortable with taking taking to new technology and new systems, where others it takes a little bit longer and they're less comfortable with that. So we have to bear that in mind when you run a project like this. Yusman can import data, Excel or CSV file into the platform. Yeah, we can take data in various different forms. If you're using, also in terms of getting data back out of Checkware, we work across many research projects, so we're quite used to integrating with systems like SPSS for analysis. We also can share data via HL7 or other means. So we're pretty flexible about getting data in and out of Checkware. Okay, we'll probably give it another minute or so. If there's any more questions, drop them in. This session's also been recorded, so if people would like a copy of that, this can be made available to them. I suspect we will be uploading it to YouTube in due course, so watch that space too. Thank you, Yusman. Thanks for joining us.